we've talked a lot today about the notion of cultural change, getting treatment to people when they need it, the opportunity from the Affordable Care Act and the parity regulations. This is right on top of us now. And this is something we all need to organize, different voices from different places, different communities. This is an opportunity. We talked a lot about and Linda talked about it earlier, about the implications of Newtown and the whole notion of timing that the Senator talked about. This is our time, and this is our opportunity. So thank you, Senator. Let me let me start with this. As Linda said, that Newtown created a lot of conversations in this country, and from all sorts of circles, the media paid attention on a level we haven't seen before. But the conversation in many cases was about guns and violence. And although a significant majority of people with serious mental illness are not violent, the mass tragedies that occurred in Tucson, Aurora, and Newtown, and the Navy Yard have caused people to finally ask, people who have never paid attention to this issue before, what's wrong with the mental health care system? So there is a level of dialogue out there, a level of interest out there that we haven't seen before. And that's why there's opportunity in the Congress and in the state legislature, and particularly in local communities, to finally get something done, finally take responsibility for doing something positive and sustainable in the mental health systems across the country. This is what today is really about. As horrible as these tragedies were, the Obama administration, for the first time in my experience, we had a president and a vice president organize around community dialogues and take some responsibility for moving forward with policy changes. As I said, it's time to bring mental illness out of the closet once and for all. As a society, we've perpetuated misinformation, stigma, and discrimination towards people with mental illness by refusing to talk about mental health care. Change happens in communities. That's why these dialogues that are happening around the country are so important. People are paying attention to this issue, sometimes for the wrong reasons. It's our responsibility to kind of redirect that conversation back to where it needs to be. Today's summit's also intended to foster education and dialogue, to shift the conversation from perceptions of hopelessness and suffering frequently associated with mental illness to perceptions of recovery and resiliency. I talked about a culture change. I talked about a revolution. It's talked about bringing the best practices, what we know, how to get the services to people when they need them, and how to change, make change in communities so we don't continue to do what we've always done, that we actually bring change moving forward. With the appropriate services and support, persons with mental illness can recover. We know that now. Many people, including some of you you'll hear today, are living productive and meaningful lives in communities despite having a serious mental illness. People do recover. People do return to their community. They return to their lives. Today you'll hear about strategies that have been identified as essential in designing and providing services and supports to people living with serious mental illness. These strategies include early intervention, creative use of technology, integration of services and finances, and continuity of care. There is not one size that fits all to solve the problems in the mental health crisis in this country. But the programs you'll hear today serve as models to consider in finding solutions. At this time, I'd like to welcome representatives from the Center for Healthcare Services, Henderson Behavioral Health, VinFin, and the Village to the stage to kick off today's first panel. This panel is entitled Models for Change, 4 Communities Making Strides that Aim to Improve the Lives of Those with Serious Mental Illness in the Communities that They Live. I'd also like to welcome today's moderator, Pete Early, a nationally recognized journalist and author who's penned 13 books, including the New York Times bestseller, The Hut House, and the 2007 Pulitzer Prize finalist, Crazy, A Father's Search Through Mental Health America's Mental Health Madness, which chronicles his son's battle with bipolar disorder. Pete.
Good morning. I'm absolutely thrilled to be here. Thank you so much for coming. We have a lot to cover, so I want to jump right into it. But first, I got a few housekeeping duties. I want to mention there's a hashtag for this conference, this summit. It's #C4MH. And if you know what I just said, then you probably are not like me and don't keep using AOL. Okay. I'm really thrilled to be here today. I am the father of a son with a severe mental illness. I'm the father of a son with a severe mental illness who's been arrested. I'm the father of a son with a severe mental illness who has recovered and is absolutely doing fantastic today because he finally, after 4 major breakdowns and years of struggling, got the help that he needed. And that's why I'm excited today, because the people who are sitting up here today know how to help. This is not a question of us not knowing what to do. I have been to every state but Mississippi and Hawaii. It's not a question of we don't know how to help people with mental illness. We're just not doing it, and that's what we need to change. You know, in 2002, the President's new Freedom Commission declared that our mental health system was in disarray and was not, quote, oriented to the single most important goal of people it serves, the hope of recovery. The commission said the mental health system was such a maze instead of a coordinated system. It said that it was like navigating through a maze, and people with mental illness and their families were left to try to get through this maze when they were often the least equipped to actually do it. 50%, now this was in 2002, so you can see how much of a step we've made. 50% of persons who needed mental health treatment did not receive it. And what did Mike just say a few minutes ago? I think it was 41% or close to 50%. Mike Hoagland, who many of us know, said the so-called mental health system is fragmented, such a disarray that it can't get the services of people who need them. Obama said just a few months ago, for years our mental health system has struggled. And I receive emails every day from parents who are saying, what can I do? Please help me. How do I do this? And you don't have to look very far to see the problems. I live in Fairfax County. Do you know today, if you have a breakdown in Fairfax County and you call the county for help, there will be a minimum of a 5 to 7 day wait before you can even see someone. There will be a 6 to 8 week wait before you get a case manager. And if you're lucky, there will be a 9-month wait to get in any kind of housing. And if you're not a priority, there will be a 2-year wait before you even get to see extensive services and housing. Now, can you imagine if you had a heart attack and you had to do that? And I don't mean to pick on Fairfax County. I was in Des Moines, Iowa. They told me out there, some people who have breakdowns have to be driven into other states to find a local bed. I was in Seattle, Sound Mental Health, a great system. They told me they had people stockpiled in hospitals who needed help, but they would be kept there for 48 or longer hours because there were just no beds. One study showed that in America today, if you have a breakdown, the chances of you ending up in jail or prison are 3 to 1. You'll end up in jail or prison versus a hospital. Now, despite these grim statistics, 3 to 1, you'll end up in jail rather than getting help. Despite these grim statistics, there are really a lot of bright spots across the United States. I've seen many of them, and that's why I'm thrilled today to be here. We're going to examine 4 programs that have used service integration, technology, enhanced continuity of care, early intervention to better serve their communities. So I'd like to begin by introducing our 4 panelists, and I am thrilled to introduce them because I'm telling you, they're doing it right, and we need to listen to them and learn from them. Leon Evans, President and CEO of Center for Healthcare Services in San Antonio. We're going to start with him in a second because I've been through his program. Dr. Bruce Bird, President and CEO of VinFin. And I understand that name actually causes a lot of, why do you have that name? And I understand it's because that's where you originally had your location. The name, it's a cut off of both streets.
Vining and Fenwood Road.
That's right. But the real reason it was chosen was because you wanted a name that didn't have any stigma. So I think that's interesting. Paul Berry, a real leader, The Village, a program of Mental Health America of Los Angeles, and Dr. Stephen Ronick, who's the Henderson Behavioral Health. If you don't know where Henderson is, it's Fort Lauderdale. Maybe some of you went down there on some spring breaks, but we're not going to get into that, okay? So I want to start with something dear to my heart. Well, let's start first by giving each of you a few minutes to introduce yourselves, tell us what you want about yourself. So let's start at this end. Doctor, that's you.
Okay, hey, I'm Steve Ronick, and I'm the CEO with Henderson Behavioral Health, and we serve basically the greater Fort Lauderdale area and then other parts of South Florida from Palm Beach down through northern Miami. I work in a really great system with a lot of really committed, passionate people. And you know, Linda and Paul spoke earlier today about, you know, the key components for making things happen are collaboration and leadership and funding. And in my neck of the woods, we have two of those, I think. You know, we have collaboration and we have leadership. You know, Florida's out of 50 states and the District of Columbia, we're 50 in per capita spending on behavioral health. So you know, it's embarrassing, and we currently have a legislature that's not terribly committed to the work we do. So our job, my job, the people I work with, is really to try to still do great things in spite of inadequate resources. And for us, and I'll talk just very quickly, I work in a comprehensive behavioral health care system, and today we're going to talk a little bit about First Episode program, an early intervention program. And really, that program has started because we take this work personally. I take it personally, and the people that I work with take it personally. And if you heard Mr. Early's story today, you know, every time I hear a story like that, I'm really embarrassed. And it's a very, very hard thing to hear over and over again, because it shouldn't happen. And I believe that the First Episode program, the early intervention program that we're working on right now, is probably the most important thing for us to develop, for our system to develop over a 30-year period. I can't think of anything else that's more needed. Because when families first experience a loved one with a psychotic episode, it's an unbelievably frightening experience. And the biggest issue for them is they don't know what to do, and they don't know where to go. So unfortunately, the experience that you relayed is very common.
We'll get to that in just a minute.
And no one should have to go through that, and that's why
That's super.
you're giving me the hug.
Yeah. No, I want to come back to that, but I want to make sure everybody has a chance just to
Understood.
introduce themselves. I'm sorry. This is the problem when you ask a journalist or an author to go ahead.
I'm Paul Berry. I'm with The Village, a program of Mental Health America in Long Beach, California. We primarily provide comprehensive wraparound services that are integrated with a focus on recovery. And I don't know about you, but halfway through that sentence I got bored. So,
But you're not going to get bored when we start talking about what you actually do.
That's right.
be a little more focused. You know, recovery for some folks who are new to this field, it can be confused with a cure, the concept of a cure. And recovery really is something each of us is far more familiar with, because each of us at some point, some place in our life have recovered from some tragic event. It could be a divorce, it could be a loss of something loved, but we have recovered from something tragic. And what that means is that we've started to relive our life in a way that's not defined by that event. Let me give you a non-mental health related example. About 25 years or so ago, my father had a heart attack, and the typical advice for some of you who might be a little bit older, if you remember, was you had a heart attack, you go home, you quit your job, you stay close to home, you rest, keep on resting. You don't be very active. You stay away from your wife. I don't want to talk about that. So 15 years after that, in perhaps a more enlightened part of the country, my mother had a heart attack. And the intelligent and competent doctors told her, well, you're going to start exercising.
Yeah.
You're going to triple with the exercise you used to do. And they asked her, do you work? And she said, well, I'm 73, but I do volunteer at the Ronald Reagan Library. And they said, great, we want you back at that job as soon as possible. And do you have friends? Well, I do. Well, you're going to have more parties. Do you have a boyfriend? No, that's too bad. What those docs knew, the ones that treated my mom, was it was not only good for her heart, but it made life worth living to have days that weren't defined by the illness. And what the Village and Mental Health America has realized, they've come to the same conclusion, that it's not good for mental health, nor is it good for somebody's quality of life to have their mental illness define their life.
There you go. So you can see, we're going to get back to you two. I'm being
Darn.
equal opportunity hooking people here. But, you know, you're so eloquent. This is good. All right, Dr. Bird.
I'm Bruce Bird from VinFen in Cambridge, Massachusetts, and we take care of thousands of people across eastern Massachusetts with serious psychiatric disabilities and conditions. But the project I'm going to talk to you about today is based on a Center for Medicare Medicaid Innovation grant we wrote for a particular subpopulation, and that's based on the issue that we all know that people with the most serious mental illnesses when they hit middle age begin to be at risk and develop chronic multiple diseases. Diabetes, cardiometabolic problems, COPD, and that these individuals have many more health problems and die 25 years earlier. They also rely on mental health and behavioral health and medical health, which is not very well integrated. So they tend to use emergency rooms and acute care hospitals in ways that could be preventable if they had better care. That's what the grant is focused on. We have 6 community partners working with us, and Dartmouth, Dr. Steve Bartell's team that has adapted this technology that I'm going to talk about called the Health Buddy. And the Health Buddy is a small clock radio-sized device that's put in an individual's home, has 4 buttons on it. People answer simple questions, and using algorithms that are programmed, it communicates with nurses that are embedded in our outreach teams and tells the nurse when there is something urgently developed so the nurse can intervene. It also, very important, it helps the individual learn to monitor, and it prompts them and trains them on how to manage their own health and wellness and disease. So it has 2 purposes there. Dr. Bartels and his group have piloted it in New Hampshire and had very promising success. And so far today, through 9 months of the project, we're ramping up slowly there. We've had over 240 interventions that have been based on Health Buddy alerts. And we've already avoided 66 hospitalizations in emergency rooms, and that adds up to hundreds of thousands of dollars of savings so far. The sustaining funds for this, we hope, are going to come from the Massachusetts First in the Nation dual eligible Medicare Medicaid demonstration project that is trying to fund integrated care for people with Medicare and Medicaid eligibility. And that big population in Massachusetts, 90,000 people, costing all in $3.5 billion. And we are dealing with some of the people who are the most costly and the higher cost utilizers. But so far, we're getting very encouraging results.
Super. You can see they're all enthused about talking about this. Go ahead.
Hi, I'm Leon Evans from Bexar County, that's San Antonio, and I had dinner with my colleagues last night, and I can tell you the secret ingredient in all of us is we understand the relationship between hope and healing. And one of the first ladies, when I went to Bexar County as a mental health authority, I went to one of our outpatient clinics, and there was this lady in fetal position. And I approached her to see if she's okay, and she screamed. She was terrified of me. Well, later, we got her treatment, and she's a prosumer, And prosumers are people who are in recovery who support each other in getting jobs, going back to college, starting businesses, and they fight for their mental health because they're enjoying life. And her name's Michelle, and I talked to Michelle about that, and she said, well, Leon, I was treated for years. I was hospitalized 30 times. I got good medicine, great docs, but I got everything except what I really needed. And I said, what's that, Michelle? And she said, hope. And so all of us use lots of consumers. We do motivational engagement. We use family members. We create a new reality for these people where they can actually get their lives back and their relationships with family and friends. And so that's the great thing. I, at one time, was the director of community services for the Texas Department of Mental Health and Memory Retardation, and I became painfully aware about the criminalization of persons with mental illness. I'm talking about nonviolent people. We don't go to prison or jail if we have diabetes, but because of the abject failure of the public mental health system and the fact that we don't have great relationships with law enforcement and other entities, we don't speak the same language, we don't have the same mission. There's such a disconnect. People end up going in the wrong door, and terrible things happen. Well, the great thing about Bexar County, what I'm going to talk to you about, is our community collaboration. So we work jointly with families and consumers and law enforcement and judges and hospitals, and we manage this system, and we have an alternative to jail, emergency rooms, and being homeless. And we divert about 1,400 people a month now to the Restoration Center who used to go to jail and emergency rooms, mainly brought by law enforcement officers.
Let me interrupt you there, because this is exactly what we want to get into, and we're going to start with you, because 16% of people in jails and prisons have a serious mental illness. They're there because they're sick, basically. Many of them have committed smaller crimes. So tell us exactly, because I've been through your system, and it's something that could be emulated in every community and should be. So tell us briefly how yours different than what happened, for instance, to my son, where I go to an emergency room, I get arrested, that kind of thing. Tell us exactly, walk us through the jewels of your system.
Okay. Well, we wrote we're in the second round of the SAMHSA diversion grants, and almost all those grants put somebody in jail to identify people with severe mental illness so they could do discharge planning, so hopefully they could engage somebody when they got out of jail. Well, we put these community collaboration together with the help of our county judge. When I was the state director, I actually tried to get people to work together, and it didn't work. I even funded programs that didn't work.
So the key was you had somebody strong who took the lead, like Judge Leifman down in Miami.
That's right. Who's going to make us do it?
Okay.
So when I went to Bexar County, I knew if I tried to pull people together, probably nobody would have showed up. And if they had shown up, it wouldn't have been the leader, somebody that could say yes. So I went and talked to our county judge, who used to be the mayor and used to be a state senator, and I explained the problem and asked him if he would champion the cause. And he did, and he got the mayor to champion, and he's the person that convened everybody. Then we were smart enough to put a judge in charge of this collaboration to begin with. And so we learned together. We learned about law enforcement. We learned to speak their language, and so there's this trust developed. And we keep a lot of data on costs and outcomes and what's working and not working. So over the last 9 years, this has evolved to this program where I said, over 16,000 people a month are brought to an alternative to jail emergency rooms for treatment.
So you started with crisis intervention trained police officers, and then instead of taking those people to an emergency room or dumping them in the jail, you actually created a crisis drop-off center, a crisis center where people can go in and be accessed and channeled into the right programs.
That's right. That's right. In fact, the first crisis intervention training program is the 40-hour course. The role-playing is what's important. So, you have these skills to de-escalate. And so the first course that we hosted, every law enforcement officer there was made to be there by the police chief or the sheriff or somebody.
Sure.
And to a man and woman, they all said, we don't believe in these hug-a-thug programs. We're cops, not social workers. And by the end of the 40-hour course, they were all saying, oh my God, I can't believe I didn't know this before. This program is so successful that our police chief McManus is requiring every officer, including his command staff, to go through the 40-hour training. And he won't let you carry a taser unless you've been through the training, because he wants you to use verbal intervention before force.
So you changed the mind of the officers, you got a crisis drop-off center, then you also, did you not help set up mental health courts and other jail diversion reentry programs?
We do, and a lot of us have talked about the fact that, when you have a mental illness, you just don't think straight. Many times you're treatment resistant. Your illness has been so painful for family and friends. You've been disconnected in some way, and so this black rub effect really works. So we do have mental health courts and drug courts and children's courts and
now, is there a reason why that couldn't be set up in any community?
No. In fact, it's very cost effective.
How so?
Well,
you got 1,000 empty beds?
Well, in 2002, our county jail was being threatened to be shut down by the Texas Jail Standards Commission for overcrowding and deplorable conditions. Our county had to buy beds from other counties. They brought in an expert that says, you need to build another 1,000 beds on our detention center today. And that was in 2002. The last census, we grew by 350,000 people in Bexar County. never built that additional 1,000 beds, and there are 1,000 empty beds in the county jail today.
That's amazing. That is
So-
amazing. You've
so-
actually lowered that. Now,
So if you look at episode cost, you know, a lot of times we say, well, it just costs $45 or $65 to keep somebody in jail, but they're in jail for how long and how many times over and over and over again? If they go to prison, you know, if you're a nonviolent offender. In fact, I can actually prove that treatment works, and I'll do that if you want me to. But if you look at the episode cost, you know, it's whatever it is per day times, you know, every how many days you're
I'm
in
going
there.
to come
It's
back
very,
to you though,
very
because
costly.
I've made that same comparison. We all know that it costs less to do treatment, but sometimes it doesn't get through anybody's head. And so I want to come back to you in a minute and ask you what you did that actually got it through people's heads. But first, I want to use a real cool segue here and cut you off without you knowing it and go to Paul Berry, because I want to read something that you wrote. And you said, every service that MHALA programs provide is probably provided better by some specialized program somewhere else. But people rarely need just one service provided excellently. I want you to expand on that, because I have been where you get the CIT fired up, you get the judge fired up, you get somebody great like Leon who gets the community fired up. But if you don't have decent community mental health services to back that up, the best CIT, best jail diversion, it's not going to work. But you're saying something more. You were telling me today that just having a Housing First program and having an ACT team is not enough. What do you mean?
Well, just on that last example, I think there are approaches that become very vogue, such as Housing First. And we know that's an improvement over hospitalization first. But sometimes we get seduced into thinking very simply about these things and one-dimensionally. If somebody is isolated, lonely, disconnected in some very unfortunate ways, and they're homeless, we end up thinking, oh, we'll get them a place to stay. All right, we're done. As opposed to the fact that now they have a place to stay, and they're isolated, and they're lonely, and they're disconnected in some very concerning ways. I think what the village tries to do is realize that comprehensive and integrated care is the most productive, most effective way to provide somebody with a quality of life that addresses the totality of their issues. The idea that it's almost magical thinking to assume that if we medicate to the illness, the rest of the person's life will just take care of itself.
So what do you do?
Our staff, first of all, we have staff that consist of clinicians, but we have staff that consists of family members and consumers, an array of people who are passionate about this. People who can build relationships. And in building relationships, we use that as the entree to help people access assistance in an array of different parts of their life. So we're very heavy into employment. We see employment as one of the primary ways that people create an identity other than
But I have a
their
mental illness. I can't work.
Yes, you can.
Thank you.
And that's where it starts. A belief that if you have someone doing an intake, one of those intake forms for somebody who's getting services, and the form either doesn't ask about employment or asks the question this way, do you want to work? It really suggests probably not. But when they ask my daughter if she gets out of high school, they don't ask that, do you want to work? They ask, what do you want to do?
Right.
Because the assumption is that somebody has a capacity to be able to be productive. And what we've done is suck that capacity right out of our questions, right out of our treatment. So to start assuming that people have the capacity to work somewhere, maybe not 40 hours a week, maybe, but maybe not. So it's our job to figure out what other alternatives there are. The village in particular offers day labor, where someone can work for a day. It offers agency-owned businesses, the village cookie shop, where people can actually work in an agency-run business. And by the way, these aren't vocational programs. These are businesses where people are paid and they're hired and they're fired. They're real businesses. In fact, so real that the village cookie shop not only provides people with the opportunity to work, but when it created its product, the Village Cookie, it turned out in Long Beach, which is no small city, 6th largest in California, I think, it won by the Press Telegram, the reader's poll, the best dessert in Long Beach. So you've got a product produced by a nonprofit, which of course is supposed to be shoddy, it's nonprofit, which wins best product, best dessert in Long Beach.
How did you and Leon, and please join in even though I cut you other two off, how do you sell this? How do you sell this? Because I go before county commissioners and I say, look, this is going to save you money, and they're not interested. They say, well, it's not going to save me directly money during my term. It might cost me money. How do you get the community involved? How did you get the community involved, Paul, in your community? Did you?
Well, I think the effort, of course, is to show both the agency and the people we serve as assets, not liabilities to the community.
Wow.
And the Village Cookie Shop does that as people look at this product and go, really? This is quality. And it's, the thing about food, it's tactile, it smells, you taste, it's got all sorts of ways of reaching you that says this is a quality product produced by, I guess, quality people. We look towards, we have a town hall meeting that some of you have heard about and asked me about. We have a town hall meeting every Wednesday where people from the community are invited in to essentially an old New England town hall meeting where people not only give information but share stories, complain. It's a town hall meeting, where I've seen my CEO get up and talk about the death of his mother in this meeting, while someone else later in the meeting is complaining about how our program stinks. That's okay. That's okay, because that's a voice. And when people see this town hall meeting, one lady, and I know this is not pleasant to hear, but one lady who visited from a supermarket nearby said, I don't know, I expected people to be swinging from the chandeliers in here, and I can't believe how organized and professional it is. Even the people who tell you your program stinks did it respectfully. The idea of having a town hall meeting where the community is invited in, and we join their meeting, so that local neighborhood associations, we're in attendance there. We're always finding ways to connect.
Takes the fear out, and it gets more involvement.
Because it personalizes it, yes.
It puts a human face on it. Dr. Bird, you were telling about the Help Buddy, and that's actually getting people with mental illness involved in their own recovery?
Well, right. For years, we've had a system in Massachusetts for about 5 years called Community-Based Flexible Support that has teams made up of people with various disciplines, peers, nurses, substance abuse, housing, benefits, employment specialists, but we really didn't have the level of activity to coordinate medical care. So the psychiatric recovery activities of our teams are going very well, but on the medical side, we were doing very poorly. The telemetry system that we use is a system that is built that has algorithms and teaching programs for both medical problems and for psychiatric problems.
Can you explain that? You're losing me because you're too well educated.
So there's a little clock radio in your home that has 4 buttons on it, and you press yes or no buttons. And it is the program in there that's been adopted by the Dartmouth guys is designed to address your psychiatric problems, if you're depressed or anxious, or whatever it might be, or your health problems. You might have diabetes. And so answering those questions, you log in once or twice a day, you answer simple questions, and based on the questions, it takes you deeper into the program if it looks like you're in crisis. So did you monitor your diabetes today? Did you check your weight today? You might have had 3 days of heavy weight gain. Maybe it means you're in congestive heart failure. So it's got simple questions that individuals with serious mental illness have learned to use, have good adherence with it. And it also prompts you to do things correctly, both for your health and for your psychiatric problems. So these programs are tailored for each individual. You might have depression and diabetes. Steve might be working on anxiety or psychotic thinking and weight gain. And using that, there's an algorithm that goes through an internet, and the nurse practitioners that are now embedded in our community outreach teams monitor that. And if you're slipping, then they'll go out and intervene. So we had here's an example, we've got plenty of these. Woman with COPD and serious mental illness who's been in the hospitals in the winter, twice a month on the average, because her COPD gets worse and she slips into pneumonia. This winter, she didn't go into the hospital once because twice the nurse practitioner saw her slipping, went out and intervened. In one case, she was going into pneumonia. They wrote a prescription for her and kept her out of the hospital. But she's learning also triggers and things to manage her own health and wellness as she's using that device.
One of the things Paul talked about was our evolution in thinking, where it's going from a system where somebody tells you what to do to being a consumer-directed or more recovery or being a more involved thing. It sounds to me like you're also using technology to open up new avenues that we have to be open to and think about. But is the system keeping up with you and the technology? I'm just thinking about payment. Is somebody going to get paid if they don't sit right across from that patient and rubber stamp the form?
Well, the whole reason we wrote the Center for Medicare and Medicaid Innovation Grant is because some of you may have heard Massachusetts is pretty far along in healthcare reform, and managed care for the dual eligibles will change the incentives. Incentives are already changing in Massachusetts. For example, you know we have 98% of our population enrolled in healthcare coverage right now through primarily Medicaid expansion. But even on the commercial side, all of the big accountable care organizations that are forming are now at risk for rehospitalizations. And people more and more are recognizing there are two issues here. People in this population are getting poor health care, and they're costing a fortune because they're overusing emergency rooms. The new demonstration for Medicare and Medicaid eligible people will change the incentives, and one of our partners is a nonprofit managed care company called Commonwealth Care Alliance. They're one of the insurance plans under the new dual demonstration that's rolling forward in Massachusetts. They've been working with elders over 64 who are dually eligible for years. And what they found is investing in community Medicaid programs has saved so much in the acute hospital and ER side that they've actually saved on the total pot of money and helped fund those community services. So the sustaining funds for this, we believe, as individuals that we're working with, enroll in this new insurance company. And everybody's interested in three things: giving these people access to appropriate preventative care instead of the emergency room in the hospital, helping them manage their health so they have better outcomes, and of course reducing the cost.
Yeah, money, money, money. That was the three things I
Well,
thought you were going to say.
It's all about value to the
Yeah.
community.
Right, exactly. So finally, doctor, I'm back to you after being so rude. I want to talk about your studies with first-time intervention, because in my own personal, I've thought about this a lot, because the first time my son got sick, I didn't know what was going on. And as I said earlier this morning, I took him to a psychiatrist. The psychiatrist said, well, if you're lucky, he's got a drug problem, And I thought, well, what does this guy know? If you're unlucky, he has mental illness. But anyway, my point is, my son was willing to go the first time break. Is that normal? And tell us a little about your study. Or is it the first person resistance? Because we have this image that, and I know it's a false image for my son. We have an image that somebody who's having a mental break is completely, for lack of a better word, crazy, can't do any rational thinking. When in fact, I learned through my son that he could be very rational about a lot of things. He just happened to have this one thought in his head that God was talking to him and getting him, wanting him to do this one thing. But he wasn't swinging from the chandeliers, as Paul said. Well, anyway, tell us about first break.
Yeah, I think, just following up on your point in terms of, is it hard to get somebody engaged when somebody first gets sick? And the answer is, with a psychotic episode, typically it is. Because, the nature of a delusion is you believe it. It's a delusion and you can't talk someone out of it. With that said, if you have a system, if you have a behavioral health system that's easy to access, easy to use, doesn't have a lot of barriers, is not a fail-first system where you have to be sicker and sicker and do more and more dangerous things to qualify for services, you I think, exponentially increase the chances of somebody getting connected to you. Also, when somebody first has a psychotic episode, when someone first starts to get ill, families are typically much more engageable and engaged at that stage, right? Because, God forbid you have to live with someone who has an untreated or undertreated serious mental illness for 10 or 15 years, you're pretty exhausted after that, So your ability to stay engaged or get engaged at that time for a first time is really, really hard to do. So I think if you have the program, and that's been our experience, your chances of getting somebody engaged at the beginning are good. First of all, the other piece of successful early intervention programs, engagement activities are part of the program. So a lot of us all do this kind of work.
What do you mean engagement activity?
Meaning that you have to chase somebody down over
You
and
just
over
don't
again.
give them a card and say, come by my office?
Meaning you have to follow, it's not, and this is not new and it's not terribly innovative. Assertive community treatment teams have been doing this for a long time. A big part of their work, similar to an early intervention program, is that at the beginning, you might have to visit with someone, you know, every other day, every 3 days. It could go on for several months.
Paul was telling me a
develop that
story,
relationship, but it gets better and people get to trust you and you have a much better chance. And then, you know, once somebody starts to get some treatment, somebody starts to get some medication into them, very often, and then sometimes in a very short period of time, somebody's ability to accept treatment, to have a little bit more insight around their illness, gets a lot better quicker. And then it can be very dramatic from there if you have a place to go. And the reason we have been so preoccupied with early intervention and feel an obligation to make this happen and do it the right way is what I alluded to earlier, is that families are desperate. And the theme of today has been, and you've emphasized this, there's no mystery anymore. We know exactly what to do. The technology is there. The outcomes are great. We just have to do it. And, you know, some communities have better resources and better support and better collaboration and better leadership than others. Very few regions in America have everything. Massachusetts is a good example. They're pretty close to having everything. You know, California had everything and now they're taking some of it away. In Florida, I told you we have a couple of the pieces, but then you really need strong leadership, and you've got to have people who on a personal level are committed, who know what to do, who have the technical expertise, but are committed to doing it.
Okay, so you four have told us wonderful examples that we could take and move to Fowler, Colorado, or Pueblo, or Des Moines, or whatever, and implement. What is the barrier? What is stopping that from happening? Is it money? Is it leadership? Is it fear?
Well,
what
you
is
know,
Yes.
Go ahead.
Yeah.
Yes.
All of the above.
Now, is it not a priority? Is it politics? I mean, why, if we have all these great ideas, then why is the LA jail still got 2,000 people sitting in it? And why, or when I walked down here this morning, did I walk by 5 or 6 people who are homeless? I mean, what is keeping us from moving your great ideas forward? Is it a lack of political, are we so low on the political charts that we can't get that kind of attention to force this through? What is it? I know it's a big question.
Well,
What is it?
in our case, it was purely public education.
Okay.
So, you know, there are all these problems, but you don't know what you don't know. And so one of the things I did in our community collaborative was put this information together. Then we strategically went and talked to the people with leadership and money. In fact, our little collaboration, Texas legislature meets every 2 years. Our committee comes up with 4 or 5 laws we want changed. And we go to our delegation, and every session we've had at least 4 of the 5 laws changed. So, and we also look at who we're talking to. So at one time, based on our model in San Antonio, the Department of State Health Services, which is state mental health authority, wanted to go ask for some crisis dollars. And so they, in their LAR, the legislative appropriation request, asked for money. The state bureaucrat that went and talked to the chair of the Senate Finance Committee called it resiliency and disease management. That center said, I ain't paying for any voodoo social work. And so we had to go back and actually talk to a billionaire who's a champion of ours and said, listen, would you go talk to Senator Ogden and tell him the truth? This is really about saving taxpayers' dollars and improving the public safety net. And we had the data to back it up. And he said, oh, well, I believe in that. And we got the $82 million.
So it's public safety is an easier sell, Paul, than social conscience?
Yeah, it is an easier sell.
Well, it's who you're talking to. If you're talking to elected officials who don't deal with this every day, they're focused on
Money.
on certain things.
And votes.
Yeah, if you're talking, yeah, exactly. If you're talking to family members or consumers or healthcare professionals, we're interested in improving people's lives, helping them regain their functionality, living longer and healthier and happier. That doesn't necessarily sell. But everybody, if you identify the problem and you have a solution and you have the data to back it up, you'll get people's attention.
So is that important, Dr. Bird, having the data to back it up?
I was just going to say, if you think about the history, so I've been doing this for 35 years, in the last decade, we've been developing better evidence-based practices and outcomes, and now we're better at looking at the costs, the societal costs, and the actual monetary costs of these. And I think we're in a very different, better position to go to our communities and find leaders or find champions who may be interested because of the social impact or the family that they know, but also when they see the data, I think we're in a much better position to be able to engage them than we ever have been before.
So Sheriff,
Doctor, Dr.
Yeah.
Ronick, I'll give you the last word since I'm now getting the hook and I cut you
No,
off.
I mean, I really have nothing more, significant to add. I think, the theme, over and over again is about collaboration and leadership. You've heard individual success stories because we all know what to do. And then each community is local, all politics are local. You have to know how to make an influence in your particular area. And as, we talked about earlier, you have to know your audience in terms of what you have to tailor your pitch to your audience, and it is different.
But go ahead.
Yeah, I think there's two ends to this. One is that you've got the political audience that you were talking about, Leon. We've got the political audience, and we need to make sure we talk in a language that works for them, that there are outcomes, there are measurable cost savings, that we, as pure as our intent may be, we're going to have to measure whether we're effective or not, and then be able to share those, communicate those. At the other end of the spectrum, the challenge to providers is that if new money is available, if new innovative money is available for some creative alternative approaches, that we don't find ourselves using the money to do the same thing with a different name. That we are committed to the effort to try to do it better, differently, and that may include not only adding services to what we're already doing, which is most people think about pretty easily. Oh, I'll just add this. I'll just add employment to these services that I do. But what makes it very difficult to make that cost effective is that we're not really good as agencies thinking about what we're going to stop doing. And what costs us and the taxpayers money, that's not effective. So if you add employment, you need to probably, in order to afford that, to stop day treatment. You have to start to think about trade-offs, that if you're going to be providing quality services that result in additions to what you're already doing, it challenges us to do the harder thing and to try to figure out, what do we stop doing? What do we stop doing that we've been doing for years that costs us money, so we can transfer that effort?
But you don't want to cut programs that are actually helping, right?
No, you don't, but you've got to be careful about what's helping and what's not. I think
And what's
Bob,
really helping somebody move forward and that's simply helping you?
you bet. It's like Bob Drake, I think from Dartmouth, up your neck of the woods, did a lot of work on the ineffectiveness of day treatment programs versus the effectiveness of employment programs.
Okay.
And so
You got to think outside the box. You
You're
got to be
familiar
open.
with day treatment. You're comfortable with it.
Right.
The intent of wanting to do good is there, but it's not effective.
Yeah, I think the point, Paul is making is, the outcome you're looking for is changing somebody's life. The outcome is not providing the service, right? And that's
Yes.
where a lot of providers can get preoccupied with what they do, where the outcome is supposed to be to
Told
make
you
a
they were
change.
brilliant. Told you they were brilliant. Do you want to have a question from the audience or not? Does anybody have a question? Yes, sir. That's you.
David Merriman, National Criminal Justice Association. Thank you to everyone on the panel. Those in the criminal justice system are actually, some of us are very excited about the Affordable Care Act and its implications on taking folks out of the corrections population and putting them into the behavioral health sphere. With that said, can the folks on the panel talk a little bit about how they've prepared for this new influx of a new treatment resource, or in the case of the folks on the end who are in states that are not expanding, either what you're doing with the insurance marketplaces or
Yeah, I
anything
mean,
on that?
in Florida, we know we're not expanding Medicaid, at least right now. We haven't given that up completely, by the way. I mean, the governor actually has went out on, somewhat of a limb, and he's at least, and we have a Republican governor, he has supported Medicaid expansion. The House and the Senate in Florida have not. We'll get, I think, another chance at this, but there's been a lot of preparation, and we actually thought we had a chance of getting something with that. There's been a lot more rush for organizations like ours to contract more with commercial insurance companies, because now that we have parity, there's a lot more people who will have commercial insurance. A lot more people are signing up for the exchanges and getting health insurance that way. So for us, we will get to more people through commercial. Unfortunately, the epic expansion relative to capacity would have been Medicaid. The answer to a lot of it, though, is what Senator Stabenow referred to earlier, is still the Excellence in Mental Health Care Act, which is federal legislation, which would change the Medicaid reimbursement, at least for those who have Medicaid. Providers would be paid like federally qualified health care centers. That would allow you to treat a lot more people without health insurance, which, especially in states that don't support expansion, would do great relative to capacity. So that's what we're looking at.
I'd like to bring up one thing. Secretary Sebelius came to visit us several weeks ago, and I'm on NACO's Justice Committee, National Association of Counties, and I can tell you every sheriff is upset about the fact that there are people in jail that shouldn't be there because of the lack of treatment availability. And one of the rulings right now from CMS around the Affordable Health Care Act, if you're detained in jail, you're not eligible. So I just want to make the point, there's a movement here we're trying to press. There's a difference between being detained and convicted. So this is the United States, right? Why would a federal benefit be taken away from you if you're not convicted of a crime? But yet, in this situation, you won't be eligible. So you won't be eligible for mental health or substance use benefits or health care benefits. So we're trying to make the point, don't take a person's benefit away from them under the Affordable Health Care Act or even Medicaid just because you're detained in jail. A very small percent of people who get arrested actually get convicted of a crime. And so that should be an issue that we're trying to push right now too, because these are the very people that we talked about that die 25 to 29 years sooner, that if you want to bend the cost curve around healthcare, if you can do early intervention, prevention, and disease management with that group and get them engaged, then you have a real shot of helping improve people's lives, but also saving a lot of money.
That brings a point we're going to close with, because we have to move to the next panel. But we got to, as all of you said, we got to quit thinking of this as individual silos. We got to understand that this is mental health is a sheriff's issue, it's a drug issue, it's a veterans issue, it's a housing, it's a jobs, it's a whole community issue. And I think that you all have testified to that. And I think it's important to do that because, quite frankly, I'm getting in trouble here, mental health groups don't have the political clout, despite everything NAMI tries to do. But if we can bring in all these other groups, the changes I'm seeing are coming from the judges.
Right.
They're coming from law enforcement. They're coming from public safety. We got to get those people and channel them in the right direction, which we'll hear about at the next panel.
You bet.
Thank you very much.
Thank you.